today's podcast is just you and I.
That's fun.
Yes, because guess what? I had the flu.
I know you did.
And so we had to postpone some people and to rework a few things. But in the meantime, we had this subject to tackle. So, physiological HRT.
Mm-hmm.
So I thought, let's do this. Let's throw this out there today.
Great, because I really want to talk about this, make this known. It's actually not new. It's improved. It's an idea that came up really about 25 years ago, which is a brilliant idea to try to follow, mimic a woman's menstrual cycle after they in menopause or around the menopausal time. We would otherwise be using static or cyclical hormone replacement therapy. The idea was that if we could mimic the cycle of a patient in her fertility years, when women are at their physical best and healthiest, that should be beneficial. And so the idea was great. It didn't work for everybody, though. There was some side effects and so on. No major problems, but certainly some discomfort. And over the years, more research has been done. And so the delivery of the hormones is slightly different to what it was before. And but it's still on a cycle of mimicking the menstrual cycle of the woman. In other words, a follicular phase, first 2 weeks of a 28-day cycle, being estrogen dominant, peaking at the 14-day ovulation time, or similar to the ovulation time. Obviously, these patients aren't going to be ovulating. And
well, some of them are, because
if we're doing it in the perimenopausal
right, which is what I'm super excited about, because we have so many perimenopausal patients.
I think that's a huge group that will benefit from this.
Right.
But just to try to explain what we're doing, then we mimic the luteal phase, which is progesterone dominant. And there's no progesterone used in the first part of the cycle for those patients. And this has been shown to be much more helpful than static estrogen and progesterone for the good health of bones and the cardiovascular system. So it's really exaggerated or promoted the idea of a healthier way to do this. I think it's brilliant. There is lots of evidence now that didn't exist 25 years ago when the thought came up. And I knew about it then and I used it then, but have fallen out of the habit of doing it. But now with this new research, I think it's time to talk about it again.
Yeah. And we have someone coming on later next month that's been involved in the research. So she's going to be a great person to talk to. There's two things about this that I'm excited about. One that I just mentioned. We have so many perimenopausal patients, which are the hardest patients to treat.
Absolutely.
One of the hardest. If not the hardest. Yeah, because what happens is when you're perimenopausal, and it happened to feel good, you're on your way to menopause. So you're already really menopausal. They call it peri, but really
you've got the symptoms.
You have the symptoms. But you get your lab work done and someone says, your labs look fine.
Right.
But you don't feel good.
Yeah.
And where do you go? Who do you turn to? And for that patient, I would think we now have a solution where we can go, oh, you have called the right place. Not we're going to be guessing and throwing meds at you.
Come on, we haven't been doing that.
But I think it's been a little more difficult.
You're absolutely right. With the perimenopausal patient, it has been trial and error.
Yeah.
It sounds a little flippant when you said it like that, because it is based in science.
I know. I'm allowed to say things like that, though. I'm not a doctor.
You are.
Anyway.
So anyway, the point is that we've got another tool in the toolbox.
Yeah.
And this, to me, looks fantastic.
And then the other thing that excites me about this is possibly helping some of our PCOS patients.
Yeah, absolutely.
And then those patients that are doing well on the metformin, but still may be struggling with some hormonal, variants of not enough estrogen, vaginal dryness, but there are young patients.
Right.
How would this work for them?
I think it would work brilliantly. And I think this, with PCOS patients, we're stuck between treating with a birth control pill to control their cycle, or having them on metformin, which also can control their cycle. But the difference being that if the patient's on birth control pills, they have contraception. If they're on metformin, they do not. And this would alleviate the problems they're in. The hormonal replacement of birth control pill is not the same as we're doing here. And so the patient should be able to tolerate this much better and not suffer for any of the low estrogen effects of the birth control pill. And over the years, there's been just more and more of an effort to decrease the amount of estrogen in the birth control pill because it was tolerated better than patients. But it's gone a little too far that way.
Yeah. Yeah, the birth control pill is just now, I think, overprescribed for people that are in perimenopause moving towards menopause.
Yeah, absolutely.
And if you look at this new pHRT, patients would start it in perimenopause, those patients, and they would just continue to get a period.
Yeah, now that's a big feature of this system, and it's one of the reasons why a lot of patients don't want to do this. And one of the good things about menopause is
you stop getting
having a period.
But would this help with belly fat and hair loss and skin changes?
Yeah, because what this system does that other hormone replacement therapy does not do is it gives you peaks of blood levels of estrogen and progesterone at different times of the cycle. And the huge benefits from that peak of estrogen, which would normally in a normal menstrual cycle be at the time of ovulation. And that's when patients are feeling generally at their best.
Yeah.
So we're pushing that back into the program here and enabling that. So it's basically putting patients back into the hormonal status that they were in between the ages of maybe 12 and 50.
And what about just going back to the PCOS patients because they're young? What about pregnancy and being on something like this?
You most likely would not be able to get pregnant
Okay.
at that time using this
Okay.
for a couple of reasons. If we were using this system in a patient that was still ovulating, which would be a little unusual. PCOS maybe because their ovulation isn't regular. Perimenopausal, their ovulation isn't very regular. Their eggs aren't great at that age. So it's not likely that they would get pregnant. Also, the estrogen and progesterone that's given is basically suppressing the patient's own ovulatory cycle, hormonal cycle, just as the birth control pill does.
Okay.
Should we rely on this as birth control? I think that's a question. It should be fine, but should is not good enough generally when somebody doesn't want to get pregnant.
Yeah.
Oops.
And then this is topical, right?
Yes. Has all the benefits of the topical application. Has a variable, it's easy to vary the dose. And this isn't one size fits all by any means. There are 5 different levels of the program that come up, but each can be altered to suit a patient, depending on how they're feeling, when the withdrawal period is happening, how heavy it is, and so on. But there's a little more work for patients and providers with the system to be watching closely. But honestly, it seems to me to solve some of the greater problems that that women experience or risk after they start menstruating on their own, which is
Yes.
bone health and cardiovascular health. And I've been saying for a long time that even with static estrogen, progesterone, HRT, that it is safer for patients to be on HRT than not,
Yeah.
despite all the fears, concerns, and lack of knowledge, honestly,
Yeah.
for most people.
I'm really excited about this. Like I said, we're going to have people on speaking more about this and more about the studies next month. And yeah, I think it's, and you said that maybe I should go on.
I was just going to bring that up. I was wondering whether this should be recorded.
I don't know if I want to go on, but I think I should try it.
I think you should too.
See if I
See how it
feel
goes.
better, or I don't know.
Right.
Not that I don't feel good, but yeah.
There's another point about this that I think is an advantage, that for a number of patients with the usual hormone replacement therapy that's given most of the time, whether it's transdermal with a patch or a cream or even pills, that there is no peak of estrogen, and the vaginal tissues, pelvic tissues, don't get treated well enough to resolve all the symptoms, such as recurrent infections, recurrent urinary tract infections, because the tissue isn't good or as good as it could be. With these peaks, that's not necessary. Or with that doesn't happen, I should say. And so currently for patients on static, we will give them vaginal estrogen as well, because that helps with sexual function and sensation and fighting off infections and bladder infections too. So there's an additional benefit here. We don't have to use the vaginal estrogen. So a lot of patients don't like. They feel they're a little messy. And also they're expensive.
So you would never have to use the vaginal estrogen?
Correct.
Even if I started that now after going through menopause, 6 years ago?
Yeah, I think so. It would do the same as the estriol vaginal treatment that we give, or the DHEA that we use for sex.
That is a definite pro.
Yeah.
And we're working exclusively with Harbor Compounding on this, right?
Yeah.
Okay. And they deliver to your door.
They deliver to your door.
Okay. I think that's it.
Hail, rain, or snow.
That's right. Or sleet.
Sleet. All right, sleet.
When we were in New York, there was sleet.
There was sleet.
Hadn't seen sleet in a while. Yeah.
All right. To be continued.
Thank you.
Great. Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.